So the testing became available in April this year, and I've been lucky enough to have Becky with me for 12 weeks. She's worked on various different projects, but the main one would be this webinar and to disseminate information on the importance of testing and to go through the dosing guidelines, which have now been published and are available on the BOPA website, the British Oncology Pharmacy Association website. So Becky is a senior pharmacist at UCLH, working in the haematology department, and she was with us in the North Thames GMSA. So without any further ado, I will hand over to Becky to get us going. Thank you.
Hi. So good afternoon, everyone, and thank you so much for joining this afternoon, certainly during Dr. Strike. So as Lanisha said, I'm one of the pharmacists over at UCLH, currently working in the leukaemia team in the haematology department. And this presentation is going to hopefully go through the importance of TPMT and NUDT15 genotype testing, and to help us guide the dosing of 6-mercaptopurine in adult patients with acute lymphoblastic leukemia, or ALL. So this is hopefully what we're going to cover. I would like you to understand what ALL is and the underlying pathophysiology of the disease, be able to describe the role of 6-mercaptopurine in the treatment and understand its mechanism of action, understand the role of TPMT and NUDT15 in the metabolism and the detoxification of 6-MP, be able to identify the common variant alleles that contribute to reduced or absent TPMT and or NUDT15 enzyme activity, and importantly link this back to an increased risk of myelosuppression, and then understand the importance of genetic testing in patients receiving 6-MP and be able to implement the dose modifications according to a patient's phenotype. So just to say at the end, we're going to have some case studies that are quite interactive, so please engage with them and give answers, unmute yourself and speak up. So firstly, what is ALL? So it's a relatively rare malignancy and it affects about 790 people each year in the UK, and that is according to Cancer Research UK. It's a lymphoid leukemia and it essentially results from the overproduction of immature lymphocytes, which are called lymphoblasts. And it can be broadly categorised into two types, B-ALL or T-ALL, and that is based on the lineage of the cells involved. So if I just bring you over to the diagram on the right-hand side, so we start off at the top with the hematopoietic stem cell, and this is essentially an immature cell that can develop into all types of blood cells. And these are found in the peripheral blood and in the bone marrow. These will differentiate down into common lymphoid progenitors, and this is a cell which is capable of differentiating into lymphocytes. So this will then differentiate into what is called a lymphoblast, and this is where the ALL develops in this cell here. And then depending on the lineage of the ALL, it will either be due to the T lymphocytes or due to the B lymphocytes. So like I said, there's about 790 cases each year. The highest incidence is seen in children who are aged 0 to 4 years. It accounts for less than 1% of the total UK cancer cases. And the survival is really good for children. So we're looking at, in cases upwards of 90%, but in adults, not so great, sitting between 30 and 40%. And just to note that the scope of this presentation will only cover testing and dosing in adults over 25. So drilling down a bit more into the pathophysiology of the disease. So like we said, we get the malignant transformation and then uncontrolled proliferation of the abnormally differentiated progenitor cells, and this was our lymphoblasts. We get overproduction of these and therefore a high circulating number of blasts, and this can have different effects based on where these lymphoblasts are. So in the bone marrow, what we get is packing out of the bone marrow by these malignant cells, and the accumulation in the bone marrow will prevent the bone marrow from doing its normal job. And this is producing cells such as red blood cells, neutrophils, and platelets. And this therefore leads to things like infection, bleeding, and anemia. So we often see patients have low platelets and low neutrophils. In the systemic circulation, lymphoblasts can collect in different areas of the body, be it the CNS, the testes, or lymph nodes. And depending on where they accumulate, we see the downstream effects of that. So for example, if they accumulate in the CNS, we get CNS type symptoms such as headaches and blurred vision. So how do we treat it? So in general, the treatment consists of 4 phases. So the first of those is induction, and the aim of this is to achieve remission. The consolidation, the intensification, and the maintenance phases are the other 3 phases, and the aim of these 3 phases is to prevent the regrowth of the leukemia. And to note, we also give CNS prophylaxis, which will start during the induction phase and usually continues throughout all phases of treatment. And this is because these lymphoblasts can often infiltrate the spinal fluid and the meninges. And the duration of the therapy is between 2.5 and 3 years, depending on the patient and how they tolerate it. So just to note, it is quite a long treatment regimen. So what is 6-MP? It's the thiopurine, and it's used in induction, consolidation, and the maintenance phases of adult ALL treatment protocols. And it's a prodrug that is essentially metabolized to active nucleotides. And these active nucleotides are then incorporated into the DNA in competition with the natural G-base guanine. This incorporation into the DNA essentially destabilizes the DNA, and things like random methylation, base pair mismatching, and double strand breaks occur, and ultimately cell apoptosis is induced. So the two enzymes that we're talking about, so TPMT and NUDT15, these are really important enzymes in the metabolism and the inactivation of this drug 6-MP. This is a really oversimplified diagram of the metabolism of 6-MP, but hopefully it makes it quite clear. So 6-MP is taken across the cell membrane by these transporter proteins, and it can then undergo two pathways. The first pathway is an inactivation pathway, which is catalyzed by TPMT, and this is where it is inactivated by formation of a methylmercaptopurine base. The other pathway is an activation pathway, so where it flows through this pathway here, and this is where the active metabolites are formed, which are those TGNs, and these are the ones that are ultimately incorporated into either the DNA or the RNA, causing damage and then cell apoptosis. And just to note over here, NUD15 has a role where it takes the triphosphate form and catalyzes the production of the monophosphate form in an inactivation style pathway that can then undergo further processing by TPMT. And again, down here, the triphosphate form into a monophosphate form. So firstly, having a closer look at TPMT. So this is a cytosolic enzyme that has a key role in the metabolism, as we just saw. So it catalyzes the methylation of 6-MP to that inactive methylmercaptopurine base, and therefore less of that parent drug is available to go through this activation pathway here at the top and form those active TGNs. In order to exert its cytotoxic effect, 6-MP really needs the metabolism to those TGNs by the process shown on the screen. So essentially, TPMT will prevent the production of these TGNs by methylating the 6-MP. So if we have less of the TPMT enzyme, this means less of this pathway down here occurs, which means more of this parent drug is available to flow through this pathway, which means more of these active metabolites, and therefore an increased effect and increased toxicity to include things like severe bone marrow depression. TPMT is encoded by the TPMT gene, and this is located on chromosome 6p22.3. The activity is inherited as a monogenic autosomal codominant trait, and I've just broken those terms down for you on the screen there. So essentially it's caused by one single gene that is inherited on the non-sex chromosomes as opposed to the sex chromosomes. And because it's a codominant trait, both of the alleles that are inherited will contribute to that genetic trait in the patient's phenotype. And there have been multiple single nucleotide polymorphisms, or SNPs, in this TPMT gene. And essentially, these will determine the level of the enzyme activity or a patient's phenotype. There are 3 well-characterized SNPs, which result in the production of unstable proteins, which are subject to increased proteolytic degradation or breakdown and resultant loss of TPMT enzyme activity. So what are SNPs? They're essentially a form of genetic variation between individuals where a single DNA base pair is swapped for another. So if we have a look at individual 1 on the screen and individual 2 on the screen, they both have AATCG as the first 5 bases, but then individual 1 has a C and individual 2 has a T as the 6th base. And these individual base pair swaps essentially introduce variation between individuals. So 1 in 300 individuals will inherit a TPMT deficiency as an autosomal trait. And the 3 SNPs listed below, which we're going to talk about, will account for over 95% of the low activity phenotypes that we see, and they produce the most common no function alleles. So adults with a confirmed diagnosis of ALL and proposed treatment with 6-MP should be genotyped as a minimum for the following variants. So I'm just going to take a bit of time to talk you through the nomenclature. So most of the guidance now refers to what is called a star allele. So the TPMT star 2 allele, essentially what this means is that at the coding region, which is what C stands for, at position 238, we have a C instead of a G. What this means is that at amino acid position 80, we have an alanine, we have a proline instead of an alanine. So it should be an alanine, it's now a proline, and that is what gives you the effect. So for TPMT star 3b, again, coding region 460, we have an A instead of a G, and therefore we have a threonine instead of an alanine. And the same applies for the other two. There is an ethnicity prevalence of the SMP. So for example, TPMT star 2 is most common in African patients, but rare in Asian populations. So it's also really important to link back to the prevalence across different ethnicities when thinking about these genotypes. So how do we link a genotype to a phenotype? So all individuals will have 2 alleles for the TPMT gene. And like I said, since it's a codominant trait, it is the combination of the alleles an individual has that will determine their phenotype. So an individual might be homozygous, so 2 identical alleles, or heterozygous, where they have different alleles for this trait. Functional variants in a TPMT gene produce a trimodal distribution of enzyme activity, and this is normal, intermediate, or poor. So if patients are a normal metabolizer, these are those that have 2 normal function alleles. Individuals with 1 normal function and 1 no function allele are intermediate metabolizers, and individuals with 2 no function alleles will be poor metabolizers. So let's have a look at the star alleles. So the wild type allele is referred to as star 1. So patients with 2 star 1 alleles, i.e. 2 wild type alleles, will be normal metabolizers. Patients can then be heterozygous. So this is where they have a star 1 or 1 of the wild type alleles, and then 1 of any of those loss of function variant alleles that we saw on the previous slide. So be that star 2, star 3A, star 3B, or star 3C, they have 1 wild type and 1 loss of function allele. And this therefore gives them a combination phenotype, and they are an intermediate metabolizer. Patients can then be homozygous, so they can carry 2 loss of function alleles, and that they can either carry 2 of the same loss of function alleles or 2 different loss of function alleles, and this will make them poor metabolizers. So moving on to the next enzyme, NUDT15. So this is located on chromosome 13, and it encodes the NUDT hydrolase 15 protein. So what does this hydrolase do? So essentially, it hydrolyzes the active and the cytotoxic triphosphate version of GTP to its less toxic monophosphate form. So here we're talking about this pathway here. So what NUDT15 does essentially is, again, it reduces the amount of active metabolites, or the amount of those TGNs that can be incorporated into the DNA, and therefore will reduce the DNA toxic effect of 6-MP. So like with TPMT, reduced NUDT15 activity means you get less breakdown of the active TGNs, which means that more of these are available for incorporation into the DNA, which leads to increased DNA damage and cell death, and therefore ultimately and likely more toxicity for the patient. So like TPMT, the NUDT15 gene is polymorphic, and there are 21 known variant alleles. So these variants are far less well described than those of TPMT, and most of them are extremely rare, but they do exist. Deficiency of NUDT15 is found in less than 1% of individuals with European or African ancestry, but it is more common in individuals with East Asian ancestry. So down here we have the most prevalent loss of function genetic variant, and that is the NUDT15 star 3. And this is at the coding region in DNA region 415, where we have a T instead of a C, which means that we have a cysteine instead of an arginine at amino acid 139. And again, just to note, the star 1 is the normal function allele for NUDT15. So let's link the genotype and the phenotype again. So individuals will also have 2 alleles for the NUDT15 gene. They can be homozygous or heterozygous for the trait, as with TPMT. And the amino acid change that we were talking about at position 139 results in that unstable protein, which has almost no enzyme activity. And as with TPMT, patients can either carry 2 normal function alleles one normal and one loss of function allele, or two loss of function alleles, and therefore be either a normal, intermediate, or poor metabolizer. So again, same diagram. So wild type alleles, 2 star 1 alleles, they're a normal metabolizer. Heterozygous, so they carry the wild type, and one of the loss of function, they're intermediate metabolizers, or they can be homozygous for the star 3, and they will be a poor metabolizer. So that's some of the theory behind the genetics. So now let's have a look at why we should test. Hopefully I've shown you that TPMT and NUDT15 are really important enzymes in the metabolism and importantly the inactivation of 6MP. Their enzyme activity is regulated by common genetic polymorphisms, and there is now substantial evidence that links TPMT and NUDT15 genotype to phenotypic variability. So this is about tolerance and safety. So genetic variation in TPMT and NUDT15 genes will strongly influence the tolerance of 6MP and therefore the safety of 6MP therapy for the patients. And what the testing allows us to do by analysing the specific SNP locations in these genes is to identify those patients that are at risk. So essentially what we can do is identify a patient with a loss of function variant. These will have low or absent enzyme activity. They are likely going to accumulate those active metabolites or those TGNs, and therefore they're more likely to experience a severe bone marrow suppression as a side effect of their 6MP treatment. This then means that we can modify the starting dose of 6MP appropriately to prevent severe toxicity for patients. So only 89% of the population will have what is termed normal activity of TPMT, and that is when they carry the 2 wild type alleles. 10 to 11% of the population will have intermediate activity, and this means they're heterozygous with 1 variant allele. And 30 to 60% of these particular patients can't tolerate full dose. And then about 0.3% of European patients will be poor metabolizers, so therefore they will be homozygous for that variant allele, and they do risk severe myelosuppression if given full dose 6MP. And I just added at the bottom there a note to say that the starting doses of 6MP are generally high because the doses are derived from the trials, and these trials were weighted, and the outcomes were weighted by about the 90% of the population who are wild type. So actually the starting doses of 6MP that we use are generally high, especially for these patients that don't have that normal activity. So I just had a look at some of the pediatric ALL data. So in a particular study with over 1,000 participants, the approximated tolerated 6MP dose range for patients with TPMT and or NUDT15 deficiency was as below. So if they were heterozygous for either of the enzymes, they could tolerate between a 50 and a 90% of the 6MP dose. If they were heterozygous for both of these enzymes, they could only tolerate between 30 and 50% of what would be a normal 6MP dose. And if they were homozygous for either of the enzymes, they could only tolerate up to 10% of what would be the normal 6MP dose. And just to note, individuals with a loss of function allele for both of these enzymes will likely require a more substantial dose reduction. So what are these new recommendations? For any adult patient with a confirmed diagnosis of ALL and proposed treatment with 6MP should be genotyped for the following TPMT and NUDT15 variant alleles before they start treatment. So for the TPMT, it's the 4 that we were speaking about. So star 2, star 3A, which is the most common, star 3B and star 3C, and then NUDT15 star 3. So it's important to note that pharmacogenetic testing for the variants recommended will not exclude the presence of other variants that could cause individuals to be poor metabolizers. There are many factors that contribute to an individual's response to a medicine. So additional non-genetic factors that are environmental or endogenous that can affect the translation of phenotype from the genotype also has to be considered in the clinical context of a patient when applying dose modifications, or importantly, a patient that is experiencing toxicity but actually had a normal TPMT and NUDT15 initial screen. The testing is recommended, like I said, for these variants, but just to note that it does not exclude other variants that they may carry. So as with any targeted approach, rarer alleles do exist, and these may not be detected. And it's suggested that genomic lab reports should specify the variants that have been tested for, and also carry a disclaimer that the test result does not exclude the presence of other variants. If results are only available for one of the genes, prescribing recommendations based on that result should be implemented, with the caveat that there is missing information which could have implications for the patient. And in the case of missing results or unexpected toxicities, the ethnic distribution of variant alleles should be considered. So, for example, the fact that NUDT15 variant is higher among Asian and Hispanic patients, and that TPMT variation is higher among European and African patients. So how can I order a test? Individual organisations should have a clear procedure for requesting TPMT and NUDT15 genotyping. And testing should really be done at the point of diagnosis as part of the initial panel test to ensure that the relevant genetic information is available prior to starting 6MP. Testing will be done as part of a larger panel test and reported through the SIH-MDS network. And each institution should work with the appropriate testing laboratory to aim for a clinically appropriate turnaround time. And how do we interpret the results? The patients who are identified as having one or more loss of function alleles should be considered for dose modification based on their individual genotype. And to note, genotype guided dosing will only really apply to starting doses, and subsequent dosing should be guided by monitoring of myelosuppression and response to treatment. So essentially, if a patient tolerates the dose reduction, the doses can be titrated up to ensure that the patient gets the best exposure to the medicine to treat the condition. Clinicians should evaluate the markers of disease progression in conjunction with the myelosuppression and adjust the treatment as necessary according to the response and the stage of treatment. And if a patient experiences toxicity in the context of what would have been a normal TPMT and or NUDT15 genotype result, the 6MP should be reduced or held and then restarted in line with standard ALL protocols at a suitable dose once the investigations have been carried out. And like I said, at that point, if a patient is experiencing toxicity with a normal result, the presence of a TPMT or NUDT15 variant that has not been tested for should be considered. Dose modifications. So I'm first going to have a look at what the standard dosing of 6MP would be. So in ALL adult protocols, it's typically 60 milligram per meter squared per day during induction and consolidation, and 75 milligram per meter squared per day during the maintenance phase. Doses are slightly lower in the protocols for the older patients, so things like UCAR 60 plus, and this is 50 milligram per meter squared per day in consolidation, and between 25 and 75 milligram per meter squared per day in maintenance. During maintenance treatment, the doses of 6MP are titrated upwards in increments at 4 weekly intervals to maintain a neutrophil count of 0.75 to 1.5 and a platelet count of 75 to 150. And just to note, there is no maximum dose of 6MP. If the neutrophil count falls below 0.75, 6MP should be reduced by 50%. And if the neutrophil count falls below 0.5, the 6MP should be stopped until the neutrophil count improves. And similar adjustments will be made to maintain the platelet count between the range 75 and 150. Response to 6MP therapy is highly variable in terms of marrow suppression, so it varies quite a bit between patients. The ability of the patient to form active TGM metabolites from the parent prodrug is really important in terms of disease control and the risk of disease relapse. And dose adjustments in the context of the neutrophil and the platelet count remain important to ensure that the patient continues to derive the maximum benefit from their treatment. And this is irrespective of their genotype result. This slide is very busy, but we're going to talk through the table. So this is the recommended dosing of 6MP by TPMT phenotype. And this is baseline assuming that your NUDT15 phenotype is that they are a normal metabolizer. So wild type patients, they don't carry any loss of function variant alleles. They've got the 2 star1 alleles. They're a normal metabolizer and therefore standard dosing of 6MP as previously discussed and as per the protocols. Heterozygous patients. So these are patients that carry one of the wild type alleles and one of the loss of function alleles. These are your intermediate metabolizers. So the recommendation is that doses should not exceed 60 milligram per meter squared per day in any treatment phase. And if the dosing is tolerated, the dose can be increased in 25% increments after a minimum of 2 weeks. And they generally will tolerate a dose between 50 and 60 milligram per meter squared per day. Homozygous patients. So these are your patients who carry 2 loss of function alleles, either the same allele, which makes them homozygous, or different loss of function alleles, which makes them a compound heterozygous patient. But either of these are poor metabolizers, and they are your patients that are at high risk of myelosuppression. So for these patients, we commence them at a really small dose of 5 milligram per meter squared per day. If they tolerate that dose, the dose can be increased in 10% increments after a minimum of 4 weeks of treatment. So now having a look at NUDT15, it's slightly easier because we only have one loss of function variant currently. So again, these recommendations are based on the fact that TPMT phenotype is assumed to be normal. So your wild type patients, no variant alleles, 2 wild type star 1 alleles, normal metabolizers, standard doses of 6 MP. So your heterozygotes, and these are your patients that carry the wild type allele and 1 loss of function star 3 allele. These are your intermediate metabolizers, and starting doses should again not exceed 60 milligram per meter squared per day in any treatment phase. And as with the TPMT intermediate metabolizers, the doses can be increased in 25% increments after a minimum of 2 weeks of treatment, and they will generally tolerate a dose between 50 and 60 milligram per meter squared per day. And then we've got your homozygous patients. So these are your patients who carry 2 loss of function star 3 variant alleles. These are your poor metabolizer patients, and again, your ones at high risk of myelosuppression. So as before, we would start the dosing at 5 milligram per meter squared per day, and if tolerated, can increase in 10% increments after a minimum of 4 weeks of treatment. So what do we do in our combination phenotype patients? So this is what is in the table below. So essentially, if your patients are a combination phenotype in any combination, be that anything other than a normal metabolizer, so an intermediate metabolizer at both, a poor metabolizer at both, or an intermediate and a poor metabolizer at either or of those enzymes, the guidance is the same. So we would again commence the dosing at that small dose of 5 milligram per meter squared per day, and if tolerated, increase in 10% increments after a minimum of 4 weeks of treatment. So just to note here, the 2 genes, so TPMT and NUDT15, are independent, and the likelihood of an individual being intermediate or poor metabolizer for both essentially relies on the population frequencies for the different variant alleles. I just want to take one slide just to talk about phenotype versus genotype testing. So TPMT activity can also be tested using an enzyme activity assay, and this is called a phenotyping assay. And what this does is essentially directly measure the TPMT enzyme activity in red blood cells. There is no clinically available assay that is similar to this for NUDT15. So the advantage of this is that you can identify individuals that have got low TPMT activity due to your rarer variant alleles that aren't currently recommended for testing or tested for. But in leukemia patients, the concordance between the TPMT phenotype and the genotype is poor, and this is due to the three reasons listed below. So leukemia patients tend to have a greatly reduced red cell TPMT activity due to atypical hematopoiesis as a result of their disease. Anemia associated with ALL due to deficient red blood cell production also occurs, and they have an excess of relatively older red blood cells in their circulating blood. And they're usually receiving chemotherapy, so this can cause a higher level of TPMT activity, and this is likely due to the opposite of having an excess of young, immature red blood cells, which will inherently have a higher TPMT activity. So for either one of these reasons individually or a combination of these reasons, the concordance in these patients is poor. Phenotype testing may also not be accurate in a patient who has had a recent blood transfusion, which leukemia patients sometimes will have. So essentially, the guidance here is to avoid an incorrect TPMT status being recorded. Genotype testing would be the one that is recommended for leukemia patients. So in summary, TPMT and NUDT15 act as negative modulators of both 6-MP activation and toxicity. TPMT was that enzyme that metabolizes 6-MP to an inactive methyl-mercaptopurine base. So less TPMT activity means reduced inactivation of 6-MP and therefore an increased toxic effect. And NUDT15 was the one that dephosphorylates your active metabolites to prevent their incorporation into that DNA. And again, a lack of NUDT15 activity means that you've got more of those active TGNs available, increasing the DNA damage and cell death, and therefore increasing the toxic effect of the 6-MP. As we've seen, the activity of these enzymes is influenced by genetic variability in the genes. TPMT and NUDT15 variant alleles are associated with decreased or absent enzymatic activity, and this is a major contributing factor to 6-MP-induced myelosuppression in leukemia patients. And patients with one or more of these variant alleles are at increased risk of toxicity and risk of severe myelosuppression with normal doses of 6-MP. So essentially, we're using this pathway to identify those at-risk patients who are at risk of that myelosuppression if we give them what would be the normal 6-MP dosing. The genotype testing for these two genes should be considered for all patients treated with 6-MP. Testing can identify those individuals at increased risk, and that will allow us to take into account dose modifications without compromising disease control. The alleles suggested for testing are the most common variants in most populations, but as we've discussed, the testing will not pick up the rarer variants. And the presence of that rare variant must always be considered in the event of severe toxicity in the context of a normal TPMT and NUDT15 level. So hopefully, you now understand what ALL is and the underlying pathophysiology of the disease. You can describe the role of 6-MP in ALL treatment and understand its mechanism for action. Importantly, understand the role of these two enzymes in the metabolism and the detoxification of 6-mercaptopurine. You can identify the common variant alleles that contribute to reduced enzyme activity and link this back to an increased risk of toxicity for the patients. And then understand the importance of genetic testing in patients who are going to receive this 6-MP, and importantly, be able to implement dose modifications according to a patient's phenotype. And these are some of the references that I've used in this presentation. Okay, so that's the end of the theory part. So I'm now going to go through 3 case studies. So the first patient, Mrs. MK. She's a 50-year-old female, and she was diagnosed with B-ALL in January 2022. She was admitted to hospital with pancytopenia, and her blood results are shown there on screen. She completed induction cycle 1 as per the UCAL protocol, and this would be the standard treatment for patients aged between 25 and 65 years, and she count recovered. And she was due to start induction cycle 2, which contains 6-mercaptopurine at a dose of 60 mg per meter squared once a day for 28 days. For scenario 1 for this patient, you check on her health record at the point when you're screening that 6-MP, and there is no TPMT or NUDT15 genotyping. You request this urgently, but you're told that the turnaround time is up to a week. What do you do? So annoyingly, it's actually showing the answers on the screen, so we'll just talk through them. So essentially the options are, do you proceed with 6-MP at a dose of 60 mg per meter squared once a day, which would be the recommended full dose, and amend the dose if you need to when the result comes back? Do you delay starting the induction phase until you have the genotype result? Or do you proceed with a reduced dose of 6-MP? And if so, what dose do you choose? So essentially, what the consultant team here would likely do is we would likely reduce the dose as if they were deficient and proceed with the reduced dose post MDT discussion. But essentially, it depends on the patient. So ideally, you would have a genotype result back because that would have been sent at the beginning of treatment. And actually, I think the conversations that need to happen are at the beginning of the treatment to check that everything that needs to be sent is sent, so that you have the results back to inform your decisions later on. But it would likely be a discussion between B and C. So in some patients, they would potentially delay the starting of the induction phase 2 until that result's back. Or in other patients, we would proceed with the reduced dose of 6-MP but then have to check the genotype result when it comes back to either clarify the dose is okay to continue at reduced dose, or actually if the patient's genotype comes back as normal, increase up to full dose 6 mp. Okay, so the next scenario was a TPMT deficiency. So essentially you check on the health record and there is a TPMT genotype result, and it is TPMT *1 *3C. So what phenotype does this genotype confer? So essentially she's a heterozygote. She's got one wild type allele, which is the *1, and she's got one loss of function variant allele. So that makes her an intermediate metabolizer. So what does this mean in terms of her TPMT enzyme activity? So she's going to have reduced enzyme activity, and therefore she is at risk of increased myelosuppression if we give her a standard dose of 6 mp. So what starting dose would you recommend? So if we think back to the table, the guidance is that the starting dose should not exceed 60 milligram per meter squared per day in any of the treatment phases, and that the patient would normally tolerate between 50 and 60 milligram per meter squared per day. So we would probably start her at 50 milligram per meter squared per day and monitor both her response to treatment and her myelosuppression. She's then reviewed by the doctors, and she's experienced no myelosuppression. Do you amend her dose? So essentially, yes, she's tolerated the dose, so we can increase it. So we can increase it in 25% increments after she's had a particular dose for a minimum of 2 weeks. And then the final scenario is a TPMT deficiency. So you now check on her health record, and there is a TPMT genotype result that reads below. It's TPMT *2 *3C. So this time, this suggests she is a compound heterozygote for 2 different loss of function variant alleles, which means that she is a poor metabolizer. This therefore means that she has little or no enzyme activity, and therefore at a really high risk of increased myelosuppression with standard doses of 6 mp. So the starting dose that we would recommend here would be that small dose of 5 milligram per meter squared per day. She is then reviewed by the doctors, and she has experienced no myelosuppression. Do you amend her dose? And again, yes, she's tolerated the dose, no myelosuppression, so we can increase that dose to give her the best exposure to the medicine for her disease. But this time the dose increase should only be 10% increments, and this would be after a minimum of a 4-week treatment period with the particular dose that she is on. And that's all that's in the presentation. So thank you very much.